Thank you very much for the invitation and the opportunity to speak on this topic. This picture is called The Castle in the Pyrenees, and it's by Magritte, and it summarises a lot of what I'm going to say. My purpose is not to tell you what to think, but it is to give you some things to think about. I once spent an Easter weekend on the island of Egg in the Inner Hebrides, and the island's known for its quartz beach called the Singing Sands, on account of the squeaking noise it makes when you walk on it when it's dry. So we tried walking on the Singing Sands without effect. Possibly it wasn't dry enough, but maybe it was how we were walking. So we tried running and jumping and stamping and doing all these things at the same time with no effect. And there was a simple explanation, which was that we were on the wrong beach. And the relevance of that will become apparent. Now, my invitation to speak, I think, comes from a talk at the ISH satellite last year in Sydney. Underneath the Harbour Bridge, we discussed gaps in hypertension care. Sydney Harbour Bridge was designed by a Scotsman, Thomas Tate from Paisley. He didn't design the whole bridge, just the granite towers at either end. And despite their solid appearance, they contribute nothing to the structural strength or function of the bridge, which were built simply to reassure the public. I'll come back to that. Back in 1967, the US veteran study showed that treating moderate to severely high blood pressure could prevent strokes and save lives. It was the first of several randomized controlled trials showing not only the effectiveness of medical interventions, but also transforming the significance of health care. Whereas previously health care had simply responded to the health problems of society with their many social determinants outside health care, when health care started to make a difference, it became itself a social determinant. The implication is clear, although seldom recognized and hardly ever mentioned. If healthcare is delivered inequitably, it will itself widen inequality. So we need to know about and address gaps in the delivery of effective care for people with cardiovascular diseases and risks. And unlike Thomas Tate's contribution to the Harbour Bridge, our concern is not just to reassure the public, it's to get people across. Now, of course, cerebral cardiovascular diseases and risks are best avoided, as Sir Nick Walsh pointed out, by primary prevention. And there are many things that governments and we can do to achieve that. But in countries where diseases and risks are established, the challenge of secondary and tertiary prevention is to prevent, delay, or lessen their complications. And these are strategies that need contact with the public. The rule of halves, first described in relation to programs of hypertension control. Half of the population had the blood pressures measured, half on treatment, half of those on treatment controlled. Only an eighth of the population at risk getting the best care. Poorly managed care systems leak like sieves. There was a coverage gap in which many were excluded from the outset, a quality gap in which effective care wasn't being delivered, and a continuity gap through which people continually fell out of the system. And the challenge for 20, 30 years has been to bridge these gaps, especially the gaps in quality and continuity. The doctor who led the way, the first doctor in the world to measure the blood pressure of all his patients immediately after the veteran study, was Julian Tudor Hart, now in his 80s, in his village practice in South Wales. I had the good fortune to work with him over 30 years ago, and we often presented research at this conference. The landmark epidemiological studies carried out by Bill Mile for the MRC in South Wales had shown that high blood pressure and its attendant risks were asymptomatic. So strategies to find, treat and control high blood pressure couldn't rely on demand. They depended on measurement of need. Julian measured the blood pressures of his patients not by screening, but by case finding, using his routine contacts to measure blood pressures when he could. only using other measures when the case-finding approach had failed. Famously, the last man in the village to have his blood pressure measured, a man called Charlie Dixon, took part on condition that everyone else had taken part before him. He had the highest blood pressure in the village, a diastolic of 170 and a systolic that couldn't be read on a sphygmomanometer scale. So there followed for him and others a sustained program of treating, reviewing and controlling high blood pressure, not on its own, but as part of whatever combination of problems a patient might present, including smoking, diabetes, alcohol, other medical conditions, and so on. Half of the patients attended a blood pressure clinic. The other half attended routine clinics where their other health problems could be addressed. He used epidemiology not just to find hypertensive patients and to audit his care, but also to measure what he hadn't done. The blood pressures that hadn't been measured, the patients who hadn't been followed up, the pressures which hadn't been controlled, calling this the measurement of omission, the key to the care of a whole population. By focusing on coverage over a 25-year period, he reduced premature mortality in his population by just less than 30%. It wasn't just the mass delivery of evidence-based medicine, it was unconditional, personalised continuity of care for all patients, whatever problems they presented. Didn't do it on his own, he did it in partnership with patients, whom he came to know well, initially face-to-face, eventually side-by-side. The continuity allowed flexibility, the development of long-term relationships, and trust. The initial focus on hypertension led in time to a wider focus on cardiovascular risk, highlighted by the epidemiological findings such as FRAMINGHAM. FRAMINGHAM scores still work well in discriminating between individual patients, but the FRAMINGHAM data are context-specific, originally coming from a 50% response rate in a predominantly white Italian population in Massachusetts, first studied at the height of the US coronary epidemic. In using those event rates to prevent CVD event rates now, we've often over-predicted, attributing higher levels of risk than actually apply to our patients. By using FRAMINGHAM-based scores, we were treating people with 20% 10-year risks long before the guidelines encouraged us to do so. An important feature of the FRAMINGHAM study is the shallow social gradient in CVD mortality compared to the actual social gradient in many countries. These data come from the Midspan study in Scotland, over 15,000 men and women followed up for over 30 years. It shows the social gradient in coronary deaths that the FRAMINGHAM score predicted based on the baseline data. And the next slide shows what actually happened, because FRAMINGHAM has always under-predicted events in poor areas. So by slavishly applying FRAMINGHAM, we've provided the benefits of CVD risk reduction inequitably, widening inequality in the process. In Scotland now we've got a new risk scoring system called ASSIGN, developed by Hugh Tunstall-Pedo and colleagues, based on a more recent cohort of men and women studied in the mid-1980s, followed up for 20 years. The slide shows that for two men with the same age, same blood pressure, same smoking and serum cholesterol, the 10-year risk of a CVD event is on average about 50% higher in men living in an area of severe socioeconomic deprivation compared to the most affluent. By using the ASSIGN score, we can correct the long-standing bias towards affluent groups. We recognise now that there's no such thing as a gold standard risk score. They're all context-specific in time and place, and their strengths and weaknesses partly reflect such differences between the population of origin and the population in which the scoring system is being applied. Tudor Hart's also well known as the author of the inverse care law, describing how the availability of good medical care tends to vary inversely with the need for it in the population served. It isn't a natural law in the Newtonian sense. It's a ubiquitous man-made arrangement which restricts need-based care. And it has three explanations. The first is the effect of the market, restricting care to those who can pay. The second, even in egalitarian systems providing universal coverage, the system may fail to match needs with resources. Third, competition for resources within systems ensures that those with the loudest voices, the most power, the greatest advocacy skills obtain the largest share of what's available. All these challenges are still with us. So far I've been looking back. Now I'm going to look forward. And the context is the rise of non-communicable disease in general, the prevalence of cardiovascular disease in particular, as the major cause of death in all areas of the world outside sub-Saharan Africa. Many measures of primary prevention, such as tobacco, salt, obesity, and alcohol control, require to be taken at national level and do not require clinical contact with individuals. But measures of secondary and tertiary prevention to prevent, postpone, or reduce the severity of disease complications and risks depend on systems of population contact, not only for initial ascertainment, but also for treatment and follow-up. As Jan de Messner from Ghent and several international colleagues pointed out in this Lancet editorial following the UN summit on NCDs in 2011, 90% of this work needs to be done in primary care. They argued that vertical disease-based approaches based on hypertension or even cardiovascular disease simply won't do. Horizontal systems are needed, integrating care around the needs of individuals. Of course, we need both. But one approach is dominant, possibly hypertrophied beyond the point of usefulness, whilst the other is undeveloped. In the world of evidence-based medicine, the gold standard of evidence is, of course, the randomized controlled trial. Its central purpose is to eliminate bias. How ironic that the results of randomized controlled trials, when brought together in systematic reviews and guidelines, are so biased when it comes to addressing the needs of patients in the real world. Trials systematically exclude or are systematically less likely to recruit patients with multimorbidity, especially the multimorbidity that's common in poor areas, which may be defined as not only the number, but also the severity and complexity of health and social problems in families. This paper, which appeared in the Lancet last year, is based on the primary care records of 1.8 million Scots, a representative third of the whole population. There's a strong relationship with age, no news to you. Multimorbidity, defined as having 2 or more of the 40 commonest chronic conditions, increases with age. There's a strong, consistent social gradient, with multimorbidity occurring about 15 years earlier in poorer areas. This slide shows for the commonest chronic conditions on the left, hypertension about 7 or 8 down. In each bar, the first figure on the left shows the proportion of people with that condition who only had that condition. And what it means is that for the 40 commonest chronic conditions in Scotland at least, people who have only that condition are the minority. Most people have 2 or 3 or more conditions. And the next slide shows you the conditions that they have. Hypertension is the second. A lot of the multimorbidity is concordant in the sense of involving similar conditions like hypertension, diabetes, heart failure, but much of it is also discordant, such as the 20% of hypertensives on antidepressants, or the 6th on long-term prescription analgesics. As the number of physical conditions increases across the bottom, the proportion with psychological comorbidity also increases. It's the commonest comorbidity, especially in deprived areas. And finally, although multimorbidity is commonest in the elderly, usually on the basis of hypertension plus another condition, most people with multimorbidity, with this definition, are under 65. For individual patients, multimorbidity is hard work, like having a job, having to understand several conditions, take many different pills, polypill accepted, attending different clinics, seeing different doctors and nurses. It can also be dangerous due to polypharmacy, and for clinicians there are few guidelines. For such patients, policies and services based on the single disease paradigm are inefficient. They encourage fragmentation. We don't need trials to know that fragmented care, lacking continuity and coordination, is a potent recipe for premature use of emergency services. The question isn't whether better integrated care can prevent or postpone emergencies, but by how much and in what ways. Expert witness Spike Milligan described the invention of a machine that did the work of 2 men. Unfortunately, it took 3 men to work it. The reality of over-specialized care. Now and in the future, the challenge is going to be design machines that do the work of 2, but need only 1 person to work it. There's the increasing challenge of universal coverage. In the middle of the 20th century, when universal coverage was pioneered, the challenge was simply one of inclusion, still an issue in many countries. But in countries which have solved the problem of access, there is still an elephant in the room. If care is not equitable, it will widen inequality. Healthcare is now a social determinant. The challenge of universal coverage now is that health systems should be at their best when they're needed most. Otherwise, they will widen inequality. I think am I actually running out of time, Tom?
Another 5 minutes.
Okay. Well, I'll skip that. These are slides from Glasgow showing the wide difference in healthy life expectancy between poor and affluent. And this slide shows across a gradient from affluent on the left to deprived on the right, the 2- to 3-fold increase in the prevalence of problems. And the flat line is the distribution of GPs. In England, it's actually worse. What we're doing, and have done since 1948, is ration GPs in the same way that we rationed bread, butter, and milk in World War II. Everyone gets the same. And the consequence is shown in this slide, a study of 3,000 encounters where consultations in poor areas are characterized by multimorbidity, shortage of time, lower expectations, less enablement, higher practitioner stress. The principal cause of the inverse care law is the lack of time, something that's hardly ever mentioned. We call it the deep end, never getting to the bottom of patients' problems, because healthcare doesn't work on the level, it works on the slope. I'll skip this. There are 3 GPs working in Govan. Between them, they have 60 years' experience of looking after a population of about 4,000 people. That's an enormous resource. Previously, they'd never been consulted by anybody. And we had to cross a bridge to get to them. And what they said was that for them, the silver bullet of care isn't just the pill, or the health check, or the interview, or other brief encounter, which, as in the film, nothing very much happens. It's a serial encounter between a patient and a small team over a period of time. The serial encounter with starts, stops, diversions, restarts, initially face-to-face, eventually side-by-side. In the same study of long consultations, it was shown that although patients could describe empathy in their doctor without being enabled, they never described being enabled without there being empathy. Relationships are clearly important. A striking factor of the Sydney meeting was when presenters from Belgium and Washington presented almost an identical vignette of an elderly patient with multiple morbidity failing to get quality of care from a multiplicity of services. Not a patient who's well represented in the literature, but who's commonplace in primary care. And the challenge presented by such patients is isn't simply a list of clinical targets. In the century before last, Osler told us, listen to the patient, he's telling you the diagnosis. In the future, we should listen to the patient, she is telling you her treatment goals. The key to integrated, non-fragmented care. Not the only outcome measure, but the most important one, putting others into perspective. In a study of 37 Scottish general practices, 22% of people didn't consult at all. They can access the Polypill online. Most of them are healthy, and some will live a long time without help from doctors. 62% consulted 1 to 6 times, mostly for small numbers of problems. But the other 16% consulted on average 10 times a year, and between them accounted for 1/2 of the work of primary care. Grossly underrepresented in the research system, in the research literature. So, let me conclude by jumping a couple of slides and finishing with 3 thoughts. First, in considering health systems, it's important that there's not a level playing field. We're working on a slope. If we ignore the slope, there'll be insufficient time, unmet needs, stressed practitioners, widening inequality. We can laugh at the ignorance of people who used to think the earth was flat, but that's really the same as thinking that all we have to be concerned about is access, and not what happens after access. Second, multimorbidity poses fundamental challenges to institutions based on vertical disease-based approaches. Institutions based on principles of centralization and specialization, they aren't the solution. Policies, guidelines, and evidence based on single diseases, important but not enough. Trials provide gold standard evidence, but that's not the only kind of evidence we need. On the other bank, or down on the ground, whichever metaphor you want to choose, are patients with their complexities and multiplicities of problems. As Donald Berwick in the news recently wrote, more and more healthcare practitioners will need to ask themselves not only what is it that I do, but also what is it that I'm part of. Health systems can be resource rich and people poor. They can also be resource poor but people rich. For the kind of health systems we'll need in the future, the building blocks are going to be a host of relationships between patients and practitioners, professional groups, between services, with local communities, based on mutuality and trust. And the amount of social capital in the system is going to determine its success, enabling people to live well and long with multi-morbidity. The British NHS is the only national health system which has ever been celebrated in an Olympic Games opening ceremony. It was a sentimental, nostalgic occasion, celebrating the words, last slide, Chairman, of Honorin Bevan. Illness is neither a crime for which people should be punished, nor an indulgence for which they should pay, but a misfortune, the cost of which should be paid for by the whole community. Health systems are an expression of societal values, the net product of many different interests, of voters, patients, professionals, managers, politicians, think tanks, insurance companies, the private sector. All certain they know best, but with different understandings of the public interest and how it should be met. All systems are struggling with aging populations, resource constraints, widening inequality. And the challenges are not going to go away. We may meet them well, we may meet them badly, but in either case, we are going to learn a great deal about ourselves. Thank you.
Thank you very much, Graham. It's certainly given us time to reflect on how we need to change our practice and if we can extend our consultations, but most of us don't have the time to do so. In the interest of time, can we just take one question, please? Any questions? Yes, Kennedy.
To bring the two talks together fairly evidently, why don't you do a trial of the polypill in Glasgow? The trial might defeat your object, Graham, but...
I think, well, there's two aspects of the trial. One's getting it started, and two is finishing it. And I think we are familiar with the initial challenge, but the challenge of finishing it in such a context is quite a challenge. It's not impossible. We've just completed a randomized controlled trial of extra time for consultations in very deprived practices. And the reason that such studies are rare is not that they can't be done, it's just that they're not done. So I think we would be up for that challenge.
Graham and Sir Nick, thank you very much for